Welcome, and thank you for tuning in to On the Go with CAO, a podcast by the Centers for Advanced Orthopaedics. Join us as our orthopedic specialists share their tips and advice for keeping you on the go and in the know, including the latest on how we're treating and caring for injuries and diseases of the body's bones, muscles, joints, ligaments, and tendons. We're here with over 60 offices in Virginia, Maryland, and DC to keep you active and on the go.
Welcome to the Centers for Advanced Orthopaedics On the Go with CAO podcast and video series. My name is Dr. Gurtej Singh, and I'm here with two of my esteemed colleagues, Dr. Lisa Grant and Dr. Michael DeMarco. Tonight on this podcast, we're going to discuss injuries versus degenerative conditions and how we treat them. I'd like to first start with my colleague, Dr. Grant. Dr. Grant was wondering, can you kind of explain to us a few acute injuries of the spine?
Sure, Dr. Singh. I have people that will come in with pain that started within a few days, something that happened pretty quickly. The first thing I'll ask them is, did you do anything to bring it on? And very often with these acute injuries, yes, I was bending over to pick something up, or I was helping somebody move, or I picked up the baby and I felt a sudden onset of some pain. Some people can have a sudden onset of pain with no obvious injury. They can say, I was sitting there watching TV on the couch and I got up like I always do and I had sudden pain. So that is what it's called an acute injury. Acute means something that happens pretty quickly, pretty suddenly.
So sometimes patients kind of get frustrated that they don't know what caused their pain. Is that really important?
That is important. A lot of times these people, because the pain is sometimes so intense and because it happens so quickly, a lot of these patients are not only in terrible pain and can't function well, but they're also very worried. They think something really bad has happened because they are in so much pain. And so that's where a big part of our job is to, first of all, make sure there's nothing bad going on and then reassure the patient. And the vast majority of these acute injuries are not serious, and we can get them quieted down pretty quickly.
Would something like a disc tear or a strain of the muscle, any other sort of typical acute sudden onset type things?
Yes, there's lots of structures in the spine. We got the bones. We've got the discs, which are the cushions between the bones. We have joints, which can get arthritic or get injured. We have ligaments. We have tendons. And of course, we got nerves and muscles in there. So there are a lot of structures that can be painful in the back. A lot of times people think if they're having severe pain, they can't function, that something, again, is going on with the disc or like a herniated disc or even a tear of the disc. Sometimes that can just be a bad muscle sprain or strain. And people, it's amazing sometimes how people can have awful pain, are convinced something else is going on. We do the exam, we get an MRI, and there's not much going on there. So the amount of pain that the patient is having does not always equate to how serious the problem is. But part of the part of the exam and the history is to figure out what's causing the pain. We want to figure out what's the pain generator.
Okay.
So by talking to the patient, if they did have an injury, what were you doing? What kind of position were you in? What kind of force were you lifting? And then certainly we want to know where the pain is. Where does it travel? Does it move around? Is it worse with standing? Is it worse with sitting, bending, twisting? And those can all give us a really good idea of what may be causing that pain, whether it's a disc or a joint. Sometimes people can have, even without an injury, can even have a fracture of the spine. When people get older and get thin bones, the osteoporosis, people can have a fracture in their back with no injury whatsoever, and that can cause a pretty sudden acute onset of pain. And interestingly also, people can have a fracture in the back that doesn't hurt them at all, and they never knew they had it.
Interesting. So obviously we have acute injuries. Dr. DeMarco, we must have some chronic injuries then, don't we?
Very much. The spine is just like any joint in the body. It's actually a series of joints where each bone connects to each other. And people can develop arthritis in the spine. There are what's called facet joints, which are these rear legs or closer to the skin. And then people can also, for lack of a better term, arthritis of the disc. It's a drying and a thinning and a loss of height of that disc, and there may be some small cracks in it. It loses some water content. And it's important to note that that's the normal aging of the spine. Arthritis occurs in every joint of the body as we age, and the spine is no different. Where the spine is different is the spine is also a neurologic organ. So as the arthritis advances, the spine is a series of tunnels and a canal down the middle and little channels that exit. All those spaces get smaller. And so when we see a disc herniation and a pinched nerve, it's a sudden single nerve all the way down the leg. And sometimes this is a little bit more subtle, and it may involve multiple nerves that travel. There is something called lumbar spinal stenosis, and as the tube of the spine gets smaller because of the aging of the spine, when the patient stands up, that canal gets even tighter. And the patient will say, well, if I'm sitting, I'm fine. And when they bend forward on a shopping cart or lean forward, it kind of takes away the pain. And they just get variable pain in their back or buttocks. And it's a consequence of the aging of the spine.
So when patients come in and have degeneration on their MRI or have arthritis, we shouldn't be so concerned that it's not also part of the normal aging process, like getting gray hair or getting wrinkles.
Or losing your hair.
Oh.
Or it is, and I always explain that there's a term in radiology, degenerative disc disease, but I explained it's not a disease. This is the natural aging of the spine.
Yeah.
However, it may be causing pain, and it may be causing some nerve irritation for that patient, and it causes loss of function for that patient. Just because it's a normal part of the aging process does not mean that it doesn't deserve treatment. It very much does. Just patients, as they age, they get different degrees of arthritis of the spine, and each patient gets a different amount of pain from that.
What I was also interested in, Dr. Grant, as physiatrists, we don't only focus in the spine. Are there some other degenerative conditions in the body, knees, hips, shoulders, that we also take care of?
Yes, as Dr. DeMarco pointed out, there are joints all over the body. We do have the small joints like the back and the fingers and the toes. We've got the large joints, the hips, the knees, and most joints of the body will get some degenerative changes. A lot of those degenerative or wear and tear changes are genetic. A lot of people think that, I played football when I was young, or I was in a car accident 30 years ago, and that's why I have this. Or, I've been working as a school teacher and, sitting at a computer. So most of these conditions were in the DNA, and a lot of this stuff will happen. A lot of my patients who have a lot of degenerative changes in their back or any joint, I'll ask them, does your parents have arthritis here? But all the joints can get wear and tear. The most common we see are with the replacements are going to be your hips and your knees. We're doing shoulder replacements now. Very interestingly, a lot of patients get this pain in my thumb, and I have to explain to patients that arthritis at the base of the thumb is one of the most common arthritises out there. Because this arthritis doesn't keep you from walking or doing your sports, a lot of people tend to not pay as much attention to it. But again, very, very common. And there are two types of arthritis or wear and tear we need to think about. People hear osteoarthritis, and that's the general normal wear and tear arthritis that all of us are going to get with time. This is very different from rheumatoid arthritis. Rheumatoid arthritis is a condition of the whole body. It's an illness of the body that also affects the joints. So those two things do need to be differentiated. And a lot of patients, when you think arthritis, they're thinking rheumatoid arthritis and things like that. So we do have to explain that most of these arthritic conditions are wear and tear. And any joint that is going through motion will get wear and tear.
When it does come to the knee, what are some first-line treatments that we can offer patients, or what recommendations can we give them to try to decrease that chronic knee pain?
When someone has chronic knee pain, again, I go through my little repertoire of physical therapy, medicines, sometimes an injection can help. So physical therapy can help with the arthritis. It can help, a therapist can help them do some exercises to strengthen some of the thigh muscles, to strengthen the muscles around that knee joint to make it more stable. Sometimes lifestyle changes like weight loss. If someone's an avid runner, I can't tell my runners not to run anymore, but maybe we run 2 days a week, and we maybe cycle or do some walking or swimming some of those other days. Maybe try to decrease how much pressure you're putting on that joint that's giving you the trouble. We will do medications for pain management. Sometimes if something's really inflamed, we can give a little anti-inflammatory for a couple weeks to really calm down the inflammation in that joint. If we've been through therapy and medicines and things and some lifestyle changes, we're still having a lot of pain, we can sometimes put an injection in the joint. Sometimes the knee will get some fluid, build up fluid, and we can drain that fluid and do an injection. An injection can really be done at any point during the treatment process. Sometimes it's done from the get-go if someone's really having trouble getting around and moving, or they got a big effusion or a fluid buildup. We can do that on the initial visit. Some people, again, want to be more conservative, so we'll try the more conservative things, knowing that we can go to a steroid injection to try to get the inflammation down. And if a steroid injection doesn't help, there are other things that we can inject. There's something that's become popular in more recent years called hyaluronic acid. It's actually made from the comb of the rooster, and we can inject that into the joint. And actually, that has actually shown to some degree to regenerate some cartilage and help people get some long-term benefit when the steroid itself is no longer helping. When we get to the point where those things aren't helping anymore, then we have other types of procedures, which again, ultimately trying to avoid that knee replacement if we can. And I understand, Dr. Singh, that you do some of those other types of procedures that would be the next step before or even after a failed total knee replacement.
You're right, Dr. Grant. So when patients have chronic knee arthritis that has been ongoing for a number of years and they've really just exhausted, whether it's the steroid injections, as you mentioned, the hyaluronic acid injections, the physical therapy, and the home exercise program, what we actually target are three small sensation nerves around the knee, and these are called your genicular nerves. And so what we'll do is, under an x-ray camera, we'll place three very thin needles that will help to block or deaden the nerve by injecting some Novocaine. So kind of like when you go to the dentist and they inject some Novocaine to numb your tooth, we're going to inject these three small nerves with just a little bit of Novocaine to see if we can numb the pain in your knee. And unfortunately, we know Novocaine only lasts for a couple hours, and so if that is successful, we can then do something called a radio frequency ablation, or an RFA. And these tend to give patients anywhere from 8 months to 18 months of significant 50, 60, 70% pain improvement, which can help them to continue with their lifestyle, help them maybe lose a few more pounds so that they are more of a surgical candidate, or in many patients avoid needing the surgery. So, Dr. DeMarco, we've talked some about chronic stuff, right? One of the more popular acute injuries is something called text neck. What is that?
Text neck is something that comes from constantly looking down, constantly hanging your head in this fashion while you're buried in your phone, and it's easy to get lost when you're working on that, or just getting sucked into these applications, and you lose track of time. But it's an extremely disadvantageous position for your neck to be in the whole time. And we talked earlier about muscle imbalances, and it just puts excessive pressure on these muscles in the neck, and excessive flexion. It can start to put pressure on the discs as well. So it's a muscle problem, but it also starts affecting the bones and the joints of the neck, and it's also a bit of a lifestyle problem. And when we search so hard to find the pain generators that Dr. Grant was talking about, then we have to work hard to eliminate them.
Sure.
So it's some lifestyle modification, and it's some physical therapy, and some strengthening, and some awareness. So the body was designed to be abused, and I think people should be extremely active and doing as many things as possible. But when we do something that's abnormal or for excessive periods of time, we have to prepare for that, and you have to stretch and strengthen the right muscles in the neck, and avoid some of those abnormal positions for prolonged periods of time.
When we talk about these chronic conditions in the spine, one of the things we sort of haven't talked about is, as physiatrists, as part of our training, we spend time learning how to read MRIs, right? So we can actually look at the pictures ourselves, kind of help show patients these pictures to see where that arthritic joint is and what have you. One of the new things that physicians are looking at is the size of the muscle in the back. And, as Dr. Grant had sort of mentioned, that some of these nerves go there, and when done correctly, those muscles stay well. But I'm curious, as patients get older, do those muscles stay nice and strong? What do you typically see?
The paraspinal muscle atrophy is what you're referring to, and it typically happens down low in the spine at the lower parts. And there's a couple theories, but one thought is that it's due to some chronic pinching of nerves in the back. As I was describing in the beginning of the segment, as the spine becomes arthritic and those channels or the lanes of the highway get smaller and smaller and it starts pinching on some of those nerves, yes, the major portion of that nerve goes down the limb, down the leg, but there's a small branch of that nerve that actually goes and innervates the back muscle and some of the skin. And so we're always looking down the leg for those symptoms of a pinched nerve, but on the MRI we can see some pinching of that, what's called dorsal ramus. And when that nerve gets injured, a muscle atrophies. And when we do the EMG and nerve conduction test, and we do the needle electrode portion, the EMG, we actually measure some of that in the spinal muscles. So there's a technique called paraspinal mapping, and all of that correlates with lumbar spinal stenosis.
So then I guess would one of the treatment plans be to try to strengthen those muscles, and how easy is that?
Very much. It's easy to lay out a treatment plan and it's easy to explain the exercises, but again, we have to explain it in a way and get buy-in from the patient that they're going to stick with that program to mitigate that loss and to strengthen what does exist.
So, Dr. Grant, are there? I understand that when patients have this chronic spinal stenosis, eventually they do end up getting a cortisone or a steroid injection. I understand that there are a couple different types. Some call them epidurals, some call them caudals, some call them transforaminals or selected nerves. Do you do any of these, and how do they help these patients with stenosis?
I do. They are all considered epidural steroid injections. Again, we're getting that medicine into the epidural space. It's a space between some of the soft tissues that run up and down the spine, and we can get that medicine into the space, and it can bathe the nerves and bathe the area to quiet things down. There are different approaches to the epidural. There are the classic, which is the one that you see when women have babies. It goes right down the middle of the spine, maybe a little off to one side if the pain's just primarily on one side over the other, but generally goes down the middle of the back, and it's entered in from the back of the spine. There's also something called a transforaminal epidural steroid injection. And if someone's having pain that's clearly in one nerve root area, one general area, that's what I tend to use, is that when that's coming in from the side, still in the back.
Okay.
It's just a few inches over, and we come in through the little nerve opening. Dr. DeMarco mentioned earlier that we have the spinal canal where the spinal cord and the nerves come down, and these little canals where the nerves exit. So there's different openings we can use in the spine to get the medicine into the spine. And the transforaminals, when we come in from the side where the nerves exit, then we can bathe certain nerve roots. Those procedures are nice because sometimes they can help diagnose again as well as treat.
Right.
If we're thinking somebody's having sciatica that's not quite classic, or if we think that again, for staging for surgery, is this really what's causing the pain? Sometimes we can even put a little numbing medicine right along that little nerve in addition to the steroid, and see again how they feel while they're numb. So that's the transforaminal approach, or what people call a selective nerve block. A lot of people say, am I getting a nerve block? They've heard the nerve block, and I'm like, well, technically you're not. Anytime when a numbing medicine is put around a nerve, it is a nerve block, but I generally don't use numbing medicine unless I'm actually doing the diagnostic test.
Okay.
So but a nerve block is when, again, we put numbing medicine around the nerve. Same as we talked about with the knee and the joints,
Yes.
Those little nerves. We can do that in the big nerve, the nerves that go down the leg or down the arm. We can put a little numbing medicine around that joint as well to see if, again, causing the pain, if it's the pain generator. And then there's a caudal epidural, another approach to doing an epidural. And that's done down closer to the tailbone. It's when we come in and we approach the spine from the very, very bottom of the spine. In practice, I don't do a lot of those. I think you probably do more of those than I do at this point. I just kind of really have found that the transpyramidals for me work the best.
Okay.
And you might want to talk about some of the indications where you like to use that caudal approach.
The caudal approach is very helpful when patients have had prior spinal surgery. And in the olden days with spinal surgery, you would open up the back roof of the spine, and so the approach you had talked about, the from the middle approach, you can't use anymore. And when you used to do a spinal fusion without the rods and screws, you would put bone along the sides of the spine. So now the surgeon has blocked out the straight from behind approach. He's put bone on the side, and now I can't get in from the exiting tunnels. So then we have to use the bottom tunnel, and that's sort of the caudal. I was curious, a lot of patients talk about how many injections they can get in a year, and could you sort of educate us on that?
The right answer is too many steroids are bad for you.
Okay.
The question is how much is too much steroid? And we really don't have a number for that. We will have people that will have a couple steroid injections and have a really bad side effect from the injections, where it will throw out their normal hormone balance, or they'll have they can get start getting thinning of the bones and things like that, or start getting a condition where the hip starts to die off, even after just a couple injections. There are people who, in my conservative opinion, have probably had way too many steroids in their life, and they're just fine. So the answer, there's no strong answer about how much is too much. When I first started practicing in my training, pretty conservative, I would do up to 3 injections per year per body part. Now, again, when you got, so now we're getting shots in the neck, we're getting shots in the back, we're doing the epidurals, we're doing the joint shots, and then, oh, by the way, I'm getting shots in my shoulders and my knees. When the hand doctor puts some in my thumb, then we're getting a lot of steroid. And then, okay, I've got asthma, now I'm taking steroid pills. So there, we have to be cognizant of the rest of the body and who's doing what. So both with steroid pills and with steroid shots, I do try to be somewhat conservative. I now, as I've been practicing longer, I will do up to 4 epidurals in a 12-month period.
Okay.
I won't do more than 3 in 6 months, 4 in 12 months.
Okay.
I know different colleagues, some that will do up to 6 in a year. I think my 3 a year was pretty conservative. I don't know many people doing that. Now, I also have had cases where I have patients who have multiple different issues going on with their back, and say the epidural helped them to some degree. Well, now we want to do the joints. Well, this joint didn't work. Let's try this one. Sometimes I'll do shots without steroids. I'll just do the numbing medicine to say, hey, let's figure out what you're responding to, what you're not. Kind of like that test we talked about. And then I'll come in, and once we figure out where that pain's coming from, we'll put some steroid there. But we do want to limit the overall amount of steroid we're getting, as well as how much we're putting in any particular body part.
Dr. Grant, I would like to echo your statement about being aware of how many steroid injections these patients are getting. It's not necessarily which body part they're getting, but how many they're getting overall, total. I frequently, also for continuing the steroid injections, they have to be effective and they have to work. They typically work for most people, but the duration is very variable. It could be 6 to 8 months, or it could be 6 to 8 weeks. Unfortunately, for some patients, it can be on the shorter end, especially as their disease progresses. And so in those patients, we want to be careful not to just continue the steroid shots when it's not helping enough, and then we have to look for other things.
So, we have talked a whole bunch of different options here. A couple of the up-and-coming techniques. There is a way for individuals who have 1 or 2 level spinal stenosis where we can insert a small tube into the back. We make just a minor incision. It's done in an outpatient setting, and patients go home the same day. But what we're able to do is we're able to actually, through the tube, use some instruments to snip away and actually pull out some of that overgrowing tissue. And Dr. Grant, you talked about some of the overgrowing arthritis and the ligaments that overgrow, and this opens up that highway. So the patient who was having a 1 or 2 lane highway can now have a 2 or 3 lane highway. And so the patient is able to stand up straighter, as you mentioned, Dr. DeMarco, and walk for a longer period of time. That technology is advancing into the endoscopic world. And so with the endoscope, it's a larger tube, so again, a small incision. But with a larger tube, you're able to use bigger instruments, and with bigger instruments, you can pull out bigger pieces of all this overgrowing tissue. And so you can actually get that 5-lane highway to open up to 3 or 4 lanes. And then, of course, there's always the 1-level minimally invasive surgery. And that's kind of then when we start to discuss how our surgical colleagues come into play and if surgery is really important for patients.
I try to get patients in with the spine surgeon early on in the course of this, just to have a discussion about where we think their problems are coming from, and if things got worse, what would it take to, quote, fix this, and the surgery. And it also gives the surgeon an opportunity to monitor, to co-manage that patient with us over time, to see them at one point in time, as opposed to we try a whole bunch of things and then say, oh, nothing worked, here you go, please operate. I think it's helpful for the patient to develop a relationship with the spine surgeon, and the spine surgeon to be able to observe that patient over a period of time. They may be treating with us for years before they have to go back. And I also explain to patients, the majority of patients don't go on to have spine surgery. So because treatments work along the way, or unfortunately, some patients just modify their activity to help avoid symptoms. But again, our goal is the highest level of function for these patients. So we set high goals to begin with.
I'd like to thank my colleagues, Dr. Lisa Grant, as well as Dr. Michael DeMarco from the Centers for Advanced Orthopaedics. I want to thank our listeners today for tuning in, for spending a little of your time learning more about injuries as well as chronic conditions of the spine and how we treat them. I want to encourage everyone to look up On the Go with CAO podcast and video series. You can search us where you get your favorite podcasts. You can download and subscribe. You can like and follow. You can even give us a review. We'd love to hear from you. Thank you very much.
We hope you enjoyed this episode of On the Go with CAO and invite you to tune in next time. To learn more about our upcoming episodes or to check out our online library of previously broadcast episodes, please visit cfaortho.com/hub. That's /HUB. Or search for On the Go with CAO on your favorite podcast app. Want to help keep others healthy and on the go? Then please share this episode. At CAO, you'll find over 160 orthopedic specialists committed to providing patients with an exceptional standard of care. The information contained in the On the Go with CAO podcast is for informational purposes only. It is neither intended as rendering medical advice nor as a substitute for seeking professional medical assistance. No relationship between the Centers for Advanced Orthopaedics and its practitioners may be created through On the Go with CAO. Any individual with specific questions regarding his or her individual health or treatment options should contact the Centers for Advanced Orthopaedics and schedule an appointment with one of its practitioners.